thank you again for coming. And what I decided to do tonight, it was fairly unusual format for me because, one, we want to thank Takeda Pharmaceutical for sponsoring me as a speaker to come to you. So I actually got paid by Takeda. And I'm a speaker for them for gout, for Uloric, and for Colchris. And I'm also speaker for Edarbi family of medicine, Edarbi and Edarbi-Chlor. So that's my biases, okay? Now, as Gary, Dr. Goin said, I'll keep it as practical as possible and as responsive to your needs as possible, okay? Please ask any questions at any time. Please interrupt me if you feel that I'm going wrong way, you disagree, that's perfect. There's nothing like a little bit of communication back and forth that gets reestablished the standard of practice or state-of-the-art practice. So we can do that. And I really didn't know what to bring you outside the gout. I do specialize in management of hypertension, of cardiovascular risk, chronic kidney disease, and I'm trying to stay away and keep my patients away from hospital and dialysis. So yeah, my psyche is not strong enough to handle going to dialysis day in and day out. It's just too depressing, especially in this weather. So after I moved from East Coast here, I realized that, yeah, I'm just not strong enough to be a full-time nephrologist, so I decided to become something of a kind of internist cardiovascular prevention risk. But as you know, that does not pay. Prevention doesn't pay. So I found the way to supplement my income. You know, I could have been driving a taxi like I did when I was a resident and fellow back in Moscow, yeah, Russia. Or actually in summer, I more enjoyed building up log houses, helping the professional builders to build log houses. So, you know, I've done it, but I found speaking being agreeable and within my kind of professional range. So that's why I'm here, okay? And with that, thinking about how we're going to do tonight, considering agenda not quite set up except for gout and how to treat it, and we'll talk about what's your standard and how you can do it hopefully better for the patients. I otherwise thought, okay, so I have several topics that are coming up with the patients, or with the doctors to whom I talk to during usually lunch hours, sometimes dinners, pretty much everywhere in the country. Certain topics, certain themes seem to resonate. So I gave you, I thought, okay, we cannot have 8-course dinner tonight. It's just not happening, okay? So how do we do that? And then my travel outside the country came to mind, and I remember traveling to Spain. You have that genius Spanish invention, which is called tapas. You know, and tapas are originally designed. There's several legends about how tapas originated, but what tapas is, for those of you who are not familiar, they're a small portion of food actually originally meant to cover the glass. One, to keep the fruit flies away, okay? But second, there's apparently was a law against the drunkenness, chronic drunkenness of Spaniards. Who could have imagined, right? But one of the later kings passed the law that you cannot serve drinks, cannot serve wine without food. So what the bars had to come up with, the smallest portions of food that would satisfy the law. Okay, sounds very familiar to what we're doing in practice. Sometimes we have to cut the compliance to the things that are minimum enough and actually get to the fun part of practicing medicine, which is helping patients. So I prepared for you several tapas, okay? And you can tell me which ones of you are agreeable. And we'll talk about which one you want to see first, which one you want to see last, which one you don't want to see at all. Okay? So that's where we are. So menu du jour is, first we're going to talk about gout. And in gout we have two parts. One is acute flare management, and the second part is chronic prevention. We'll talk about that. Gout is really the only chronic disease, part of metabolic syndrome, that is totally curable. Yes, you can control A1C in diabetes. It's still not as good as not having diabetes. You can control hypertension, but the effect of antihypertensives is only about half of the effect of not having hypertension naturally, and so on and so forth. So we always look at the numbers, we're trying to get to the numbers, but the disease is kind of still there. We're mitigating it. In gout, one disease you actually can eliminate. So chronic acute management role of uric acid lowering medications and Colchris, also NSAIDs, steroids, where to use them, how. I don't necessarily have all answers. Every part of the country likes different things, but we'll talk about it. And the second one is something I care dearly about, is hypertension. It's an orphan disease because, you know, how much can you charge for treating hypertension? Are there any procedures? Not yet, but they're soon going to be. They're going to zap renal arteries. Cardiologists are already totally salivating. Yeah, they're going to fry your renal arteries, sympathetic nerves in the arteries, do renal denervation intravascularly, and it apparently produces durable reduction in blood pressure. Question is, does it improve outcomes? Cardiologists want us to believe that they will, but we have heard that with stents, right? Do stents prolong survival? No. Does it improve cardiologists' lifestyle? Well, we'll leave it to cardiologists. They say their lifestyle is horrible anyway. So hypertension, right? So hypertension we still have to treat in our office painstakingly, and there's no easy answers. But I'll try to find something that fits each one of your practice. There is difficult to control hypertension, which you usually may want to send to specialists, but they may come back with not much help. What do you do? I'll give you a couple hints what to do with that. Thiazide diuretic story, probably the most important part emerging into GNC8, that all of a sudden after GNC7, when with thiazides were pushed in the front line, we realized thiazides are not the same. Hydrochlorothiazide probably should not be used at all in modern clinical practice, and the alternative chlorthalidone and indapamide are probably two evidence-based thiazides that should be used. So if you need more information there, I'll give you that. Chronotherapy, when to give medication, when to drink your wine. First thing in the morning on awakening, I can tell you. Russian proverb says if you have a couple drinks in the morning, you have the rest of the day off. Or you could do it with dinner, and apparently that improves your survival and relationship with your boss too, if you have one. But most of us are, I guess, mostly our own bosses, right? Yeah, I understand there's no glamour and cheer on that. You know what it means, right? You're the last person to get a paycheck. So apparently giving antihypertensives at night, all but amlodipine, which doesn't matter when you give, and diuretics, because you want to be humane to your patients. Okay. Other than that, pretty much everything else goes to nighttime. Improves outcomes tremendously. We can have a look at that. Something that comes up with outpatient blood pressure measurement. What do we do there? Now everybody has blood pressure machine. What do we use for the targets there, number one? And what to say if patient brings you back the list of blood pressure records, which shows that it goes anywhere from 116 to 180 over the course of the week, but average is 132 over 82. What do? You tell patients they're fine? Do you tell them like, well, you need to stop worrying that much, okay, or whatever else? Well, we'll look at that. And the final is stroke clinic. This is something that is borrowed from a little-known place called Oxford in England. They have specific Oxford protocol that decreases the incidence of secondary strokes after TIA or minor stroke by 80%. But apparently, like I came to my local hospital and said, okay, why don't you send me these patients right away? I guarantee I'll see them that day. I'll start that protocol. It will decrease incidence of secondary strokes, complete strokes by 80%. I'm not sure what was it, just callousness or pure calculations that you decrease strokes by 80%. What happens to hospital revenues? What happens to nursing homes? What happens to admissions from nursing homes? I don't know. So apparently there's no traction. But I think once we got to accountable care organizations, this type of experiences borrowed from other countries, which already have to deal with the total cost of care, would be important. So that's kind of my waiter's announcement to you about the tapas for tonight. And they are usually pieces of 4, 5, 6 slides. And they're backed up by a full presentation that's usually available in my website at renalremission.com, which you can download it with speaker notes. They also should be available in these handouts, kind of not the all slides, but the key slides out of all the talks. So once again, something that you like, you may want to expand on. So with that, while you're thinking about what else you want to hear from hypertension, let me guide you through the gout part. And before I start, I want to see if there's any questions about gout you want to address, me to address. What's bothering you?
Well, the first thing that comes to my mind is, we've always been told, especially back when our chem panels included a uric acid, that we're supposed to ignore hyperuricemia until the person had a gout event. Do you still hold with that, or should we be attending to that given the rise in chronic renal disease and the possible contribution of hyperuricemia to that?
Right. Dr. Goyen asking about management of asymptomatic hyperuricemia in patients who never had a gout flare. And well, the answer to this question, as much as I would love to talk about pathophysiology and how gout may be contributing to vascular inflammation and peripheral vascular disease, or maybe coronary artery disease, about the trials of, for example, high-dose allopurinol as anti-anginal agents and so forth, regardless of previous history of gout, it is clearly, absolutely, totally not recommended by all the societies and by package insert. Problem with that is that the drug we're more likely to use and probably will use first and foremost, allopurinol, due to its lower cost, is associated with severe, sometimes fatal, and disfiguring side effects. So trying to something that may happen, doing basically primary prevention with something that can kill or disfigure patient is very, very hard. So basically, if it would be a clean agent or reasonably clean agent, we would be pretty close there. But for now, no. So answer is asymptomatic hyperuricemia, practically of any degree, you don't treat. But nobody will prohibit you to ask patient about symptoms of gout. You may have not carrying the diagnosis of gout on paper, but you say, have you ever had inflammation of your big toe or ankle or wrist? That happened basically out of nowhere. The hallmarks of gout, how you distinguish it from arthritis or whatever else, is it's usually patient can tell you exact hour, if not within 15 minutes when it started. They didn't have it night before, they woke up in the morning, it's there. 2 p.m., I all of a sudden stood up and my ankle hurt, and now it's all swollen and red with effusion. So that is almost always gout, almost always gout. So if you go through the history, a lot of patients, especially with substantial hyperuricemia, will have a history. Then you just do a retrospective, post hoc diagnosis of presumed gout, and then you have obviously complete blank check to treat it the way you see fit, considering risks and benefits. Does it make sense? That's what you kind of do in your practice? Anybody here ever had Stevens-Johnson syndrome from allopurinol? Yes?
Sure.
You seen it?
Yes.
Yeah. Yeah, we're seeing it in life rather than in pictures, in the photos, is pretty horrifying. So yeah, once you've seen that, you start respecting allopurinol. And that's pretty much the only time dermatologists start sweating, because that's severe disease. Anything else before we start?
Tophaceous gout.
Aha.
And treating that to uric acid level of 5 or 6, and even so doing, why does it continue? Why do you still have tophaceous?
Oh, perfect. That's a perfect actually start to what we're going to talk about. So I'll answer this question in the next couple slides. So let's start with gout. Now, if you know the rules for the talks, because we have a big brother watching us every time, especially on record. So rules for this talk, I'll show you all the slides. It doesn't mean that I'm going to talk to you about all the slides, number one. Number two, that's pretty much it. So let me, all right. So question is, why do we have tophi when the uric acid level is still under 5 or 6? And this is a thermogram of a normal human being. Now, some people have cold extremities. So people even with what is called normal temperature extremities will have 28 degrees Celsius hands and feet. And uric acid solubility is highly dependent on the temperature here. So at 28, in normal person, you will have somewhere around 4, the saturation of uric acid. So you have a normal person with a tophi in the toes or fingers and uric acid of 5. It's not going to be dissolving. Just pure chemistry of the uric acid will not allow you to do that. You really have to go under 5, probably under 4. Now, jumping a little ahead, if you have case of severe tophaceous gout, disabling gout, you want patient to get better now, not in 2 years. It's a case for, Peglotti case for Cristexa. Basically, uricase, infusible uricase. You give them infusions every other week, and it takes uric acid right out, induces horrible flares, mobilization flares, which you treat with all you got, but it takes tophi out. After that, yes, you put them on uric acid lowering therapy orally for life with the best you got, and we'll talk about what's that. So that would be the answer. Next question is somebody who doesn't have tophi but continues to have flare a couple years after they've been on steady uric acid lowering therapy with uric acid under 6, even 5. What's happening? Same thing. Now, this is normal person. Now imagine person with peripheral vascular disease. Imagine person who actually also takes traditional beta blocker, which are actually vasospastic, they're vasoconstrictive. They would have even colder and colder extremities. So you may have to go further and further down to actually help that patient to live more or less normal life. So that's where we are. So with that, let's go to our first patient here. And this slide deck basically built as a, I supposed to serve as moderator, but it's going to take us till tomorrow to get through all this. So I will do modest amount of moderating, and I'll impersonate some of you. How about that? All right, so we talked about that. I promise you it's going to be quick. So understanding gout, okay? We'll skip that too. It is, by some data, some skillful manipulation of data puts it to the most common form of arthritis, which, it's not that far from there, but it's there. So I love this slide because that is where I scored some major victories with my patients and almost lost some of my primary care referral sources. How it happens. Your typical story, somebody who had gout here and there in the past, then developed arthritis, been taking Celebrex forever, or been taking Aleve over the counter 4 to 5 per day for several years, creatinine of 2, 2.5, finally gets to my office. And I look at that and I say, well, listen, you're also an ACE inhibitor and a diuretic because you have to be on it for other conditions. So this is the perfect setup for the kidney damage. So ACE inhibitor or R plus diuretic plus NSAIDs, that's how we induce acute kidney failure in rats, okay, in laboratory. So I said one of these 3 has to go. let's try to take you off NSAID, and they say, no, absolutely, my life is miserable, I cannot function. And then you look through their labs, you look through their history, you look sometimes through their fingers, toes, and all of a sudden kind of, you actually may be right here in a chronic gouty arthropathy. And I tell them, why don't we try this? Why don't you wean off your NSAID, don't stop them because people are going to get rebound headaches, rebound kind of arthralgias. Taper them down, and I'm going to give you colchicine instead, give you Colchris. And I give them a free coupon for 30 days. So that's all becomes a free experiment. And occasionally, not always, they can go off NSAID, be on a Colchris, and all of a sudden they come and say, my life is so different. And then they say, and I don't understand why Dr. such and such, I've been seeing him for years, never done it. And I usually, I would stumble in this situation. Now I know the response like that come back. I said, well, it's better be lucky than good. It's a good luck. It's a good luck. I just thought about it, decided to try it, and we just all of a sudden won't. But it is a fairly uncomfortable situation. So after that, I start looking into this particular problem. And what I found that these are people with arthritis below the knees and below the elbows. Once again, remember previous thermogram? Below elbows, below knees. That's where the gout practically always is. If it's shoulders, hips, back, no. Something else. If it is arthritis that mostly below elbows and knees, think chronic gouty arthritis. Try therapy. Try colchicine. Prednisone will help any arthritis, obviously, but colchicine is fairly specific, and then go into your rate-lowering therapy. And yeah, people go back to spending their money on cruises and send me postcards.
What would happen if you tapped a joint on one of these people and looked for gout crystals before you did this kind of experiment?
Right. So what do we do when we have a crystals? Looking for crystals. And the answer is actually right here. This is the intercritical period. So it's not even chronic gouty arthropathy. These are people who someday had gout and now are intercritical period, don't have symptoms. You tap their joints, okay, and, oh, no, it's the wrong slide, I'm sorry. It's almost like, looking at almost like this. Hold on, let me see if I passed it. Did I pass it? No. No, I didn't, okay. If you start having seizures, you can blame it on me.
Well, that's one way to make sure we see all the slides.
Right, yeah, exactly, well, good point. You know what, I lost this slide totally and completely. But basically, the majority of patients still will have crystals in the joint. So it's not going to be diagnostic, whether it's causing arthropathy or not. Therapeutic trial. That's the point I'm trying to make. And the same is true, for example, for people, let me see, maybe I'll find it, going slower. So that's prophylaxis, no. Oh, you know what? That is an older version of the same deck. That's what it was. Okay, yeah, they kind of cheated me out. But that other deck is scraped off. But basically, majority of people will have it. And how crystals actually originate in the joint, for the most part, is a break fracture of microtophi. Basically, the whole theory of gout flare kind of changed. Instead of crystals being in the joint and causing inflammation, which doesn't appear that way now, what we think happening now is that you have a microtophi which serve as a foreign bodies, basically. So they encapsulate it in a little bit of fibrous capsule, and you have giant multinuclear cells there, Langerhans cells that are trying to contain and digest them. around, but this eventually they encapsulate them the same way they encapsulate tuberculosis bacteria. But what happens when you put too much pressure on that, mechanical pressure on that tophus, either banging your foot, running, doing something on the 4th of July while also drinking beer and barbecuing, right? Then next morning you wake up, I remember banging that toe and now it's red and flared, right? So you think it's injury. No, it's not. It's gout. You fracture that tophus and you spread these crystals either in the tissue or in the joint, and that causes inflammation. That also explains why the joint that is involved in gout most often is involved in gout, because that's the single smallest joint carrying the biggest weight. Think about how you're walking. You're having all of your weight on one foot, and at some point, most of it on that exact joint, on the first metatarsophalangeal joint. Just think about how you roll your foot, right? Where is the weight? It's right there. So biggest weight, smallest joint with the biggest weight. So most of the chance to squeeze that goo into the tissue and cause inflammation. Plus, it's one of the coldest joints, right? That's where the crystal's most likely going to be anyway. So kind of gives you a little bit of perspective, a little bit of understanding of things, and give you mechanics of it. But bottom line, the second part is arthrocentesis is, well, occasionally a risky procedure. And we know what steroid injection does now, right? Anybody wants to buy steroids from compounding pharmacy and inject it in their office anymore? I don't think so. Right, so basically, but yeah, tapping the joint, especially inflamed joint, emergency room doctors love to do that. They said, okay, he came with a pretty classic gout and I tapped his joint, and I'm kind of like, oh my God, tell me you didn't do it, or you at least did a conscious sedation for that, because it is extremely painful, and most of the time it's unnecessary. The clinical diagnosis of gout is totally acceptable. It is totally acceptable. I'm trying to think if I answered the question. But basically, yeah, don't do arthrocentesis unless you have significant differential diagnosis thing going on. But and the crystals will be present there most of the time. Moving on. And like most things in life, things go from bad to worse. And that's what you kind of have to tell patients. So with time, you're going to have more and more issues. We'll skip through that. Well, actually, we can look at that. So basically, you have, once again, it is the only curable problem, metabolic problem that we have. You have hyperuricemia, supersaturation, crystal formation, then microcrystal release from a microtophi, inflammatory cascade, flare, and the whole system keeps going on and on. So there's two distinct parts: symptomatic flare and asymptomatic flare. And you know how difficult it is to treat asymptomatic disease. It is very difficult. We'll skip through that you probably all know. So let's talk about this quick patient case. Number one, as you see, it's a male, age 46. Why would 46-year-old woman would not be there as a patient with gout? Anybody had seen women in the 40s with gout? Nowadays you can. Okay, 10 years ago. Very rarely, yeah. It's usually 50s, 60s, 70s. And then they got it oftentimes worse than men, but that's a different story. I think because they love their diuretics so much. But that's kind of on a side note. I know it's sexist, but it's, I hope you excuse me for that. But anyway, reason is that estrogens are actually uricosuric. Women do not develop hyperuricemia up until they go through menopause. Yeah. So if you see a premenopausal woman who is not clearly very metabolic looking, especially on insulin and diuretics, with picture compatible with gout, think something else. Doubt that, okay? But after their 50s, after menopause, they catch up very quick. So once again, this patient, several gout flares over the past 5 years. Now, if he is a state worker and they all happen on Fridays, that's not an issue, right? But if he's your babysitter, no, you can have 46 for a babysitter. If you other important person in your life, who would be man of 46 years old.
Your babysitter's father.
You better babysitter's father, or better your co-partner, and you're going on vacation, right? You really don't want him to have a gout flare, especially when you have tickets to go to New Zealand for a few weeks, right? You really would hate that to happen. But so you think, okay, if you have several flares over the last 2 years and I have to cancel at least one of my vacation, you're going to be treated. You're going to be treated, whether you like it or not. Even you don't like it, we're going to vote, and you're going to be treated. You're going to have directly observed therapy. So anyway, so that's where we are. Non-smoker, social drinker, classic gout attack, normal blood pressure, a little overweight. Serum uric acid, what would you expect? Acute flare, serum uric acid. Maybe normal. Why would it be normal?
I don't know, but when you get acute gout, always the uric acid seems to be pretty low. You bring them back 2, 3, 4 weeks later, get a different number. I don't remember the physiology.
Right. It's actually, yeah, it's absolutely correct observation, and it's actually not physiology. It's actually chemistry of physics of supersaturated liquids. Yeah, basically, once you start precipitation cascade, once you have a supersaturated fluid, once the precipitation starts, it usually overshoots it. It actually gets it down to below saturation point, and then it recovers. So if you have gout, you would have actually the level that will be several points lower. So my advice is never, ever to do uric acid during acute attack. What it does, it gives patient one more, or your partner, one more excuse not to be treated. Right? Because the uric acid level is going to be, quote, normal. When you do it, exactly right, couple weeks. So you give him treatment, you bring him back, couple weeks, and then when you're going to start your rate-lowering therapy.
So what if you give them a nice pork sandwich, a couple of beers, and some asparagus? Is that going to abruptly raise their level, or a person who manages will a person who manages uric acid efficiently, will that not raise their serum level?
Yeah. So basically, how much we get from the food. Yeah. I realize they changed the deck on me, but I'll try to get it. Yeah, they managed not to delete this slide. We don't know how that 4th of July or Labor Day thing will change your uric acid. It probably will. But we know that the real lifestyle interventions trying to restrict all these things lower it by about 1 milligram per deciliter. Yeah, exactly. And like things like losartan, right, Cosar, that lowers it, lowers to about 0.3 to 0.4. Highly statistically significant, practically irrelevant. So may it help? Well, it may. It was nice for Merck to put it out as a promotion for Cosar, but that's where we are. What is important, though, in a dietary intervention, same as we're fighting every day, high fructose corn syrup. Fructose is the ultimate toxin, basically, for human body. In a doses of about 15 grams a day, it's metabolized through a totally different pathway. Brings triglycerides up, insulin resistance, and uric acid. It increases uric acid dramatically. So why we see so much of gout now? Part of it is thanks to the consumer choice, right? That's what they say. That's what the beverage distributor, whatever, association which struck out the tax on sugar beverages said, yeah, it's like tobacco, right? This is a choice. People choosing it. Who is paying for it? They're reaping the benefit. We're paying the bill through taxes and insurance premiums. But that's where we are. So if you want to talk to people about it, talk about beer, Switching to Russian vodka, okay. Okay, good. That's one. Number two, getting rid of the sugar in any shape or form. That will help pretty much everything in your patients. So that's where we are. So once again, dietary restrictions. What did we miss? Something fun? Yes, there's a couple fun things. All right. So next thing. So we want to resolve flare. We want to initiate therapy, and we want to keep patient flare-free. Now, this is in your handouts, and this is from the horse's mouth. Okay, this is, I don't have slide. I'm not allowed to show any illegal slides here, but there's highly legal slide which will tell you if you maintain uric acid level under 6 for 2 years, there's not going to be any more flares, period, end. So you can guarantee, practically, never say never, but guarantee patients that after 2 years of therapy, they will not have any flares. So it is indeed a curable disease. So question is, okay, so we are going to treat him with medications to control his flare, and then we're going to prescribe urate-lowering therapy, providing prophylaxis. Okay, so are we providing prophylaxis for this patient? Do you all provide, each individually, all collectively? No single opinion, no collective opinion? Yeah, what do you do? So say 2 weeks later you see that patient. I give him the lab slip when you have that gout attack. Say you come to see me 2 weeks, you do the lab before, they come, the uric acid level is 8.5. Okay, flare resolved 2 hours, 3 hours after they get the dose of Colchicine or prednisone, right? And you kind of have clear case. They come to you, you have everything else. You give them allopurinol, for example, and do you prophylax? Do you not prophylax?
So I don't, but I explain to them the risk, and I make sure they have access to treatment.
That's one way to do it. And by access, you mean what? Have it on hand, have a prescription, or call you on Monday when they have a flare on Friday?
Yeah, either that they have a valid prescription in hand and ready access to a pharmacy, or that they have the pills on hand.
Good.
So that they understand how to use it.
Right. Very good. So that's totally one way of doing it, but this is trusting too much to the patient. They remember it. Number two, that they don't lose prescription. Number two, that the pharmacy is actually open, because it usually happens in most inconvenient hours, sometimes away from home. But yeah, this is one way of doing it. So no prophylaxis, just as needed. Okay? Other thoughts?
So previously it would be colchicine for at least a month, but there's been pushback on the cost.
Right.
Yeah, I don't know how to get around that.
So colchicine push on the cost. You obviously don't want to use prednisone for weeks and weeks. NSAIDs, you figure out I'm a fan of NSAIDs. They build up my practice. As much as I love to hate them, you know, if you stop prescribing them, I'll have to do more speaking. But anyway, but that's where we are. Okay, yeah, there's no easy solution. We'll try to make one. But if otherwise, if you have a direct underground railroad going to Canada, right, or from Canada, and you have a colchicine available for the pennies, would you prescribe prevention?
Historically, prescribed it for 6 months before you use allopurinol. That was the historical way before it was extremely expensive.
Right. So exactly. So before we would give it for 6 months. Actually, some people would argue for the year. And that's the slide that you already been looking at. And that exactly what happens. This is your probability of flares. And this is with use of twice daily colchicine for prophylaxis, which is overkill, I think. But yes, you go from 2 flares in the first 3 months per patient. Okay? Think about it. This is ouch. Very few people who had 1 or 2 flares a year, after having 2 flares in the first 3 months, will think that you know what you're doing. Even though you're doing the right thing, you just have to tell them, you have to believe in the future, and especially in afterlife, right? But anyway, so down to 0.5. 3 to 6 months, less risk, but still there, and about 1 flare. So what the right thing to do? Yes, 6 months prophylaxis. This is not, this is kind of the mean number of flares, okay? Mean is not median, okay? This is very good way of manipulating the data. But you have about 80% of patients will experience flare. So 20% will get away. So question is, do we prophylax, do we not prophylax? If we do not prophylax proactively, I suggest patients have it on their hands. So what I do in my practice, I give them that 7-day Colchris for free coupon, okay, with a prescription. Tell them, fill it on your way out. Have it at home. Take it everywhere you go. And if you have a first twinge, if it's starting, start then. Don't wait until fully blown. So, works for me. It's free. Second thing, the patients who started having flares tend to have flares afterwards. So the lesson from that is, once they have a flare, keep it on for 6 months or maybe up to a year, depending on how bad flare is and how bad you think they're going to react to another flare. So that would be my advice. What do you use? Once again, NSAIDs are acceptable for long-term use, except they feed nephrologists and cause GI bleeds and increase cardiovascular mortality, but these minor points. Right. Colchris has a high cost, really doesn't kill anyone, but has high cost. Did I say have high cost? I did. Okay, good. So that's where we are. There's a couple tricks about Colchris too, so we'll talk about it. Now, what dose of, and everybody starts on allopurinol, I assume, right? Nobody wants to deal with a prior authorization with a Uloric. Is that my understanding? Or there's brave souls who go ahead with a Uloric? No?
It all depends on the creatinine.
Oh, that's a very good point. Yes.
You know, I had a patient who's been in the ICU many times with multiple heart conditions. His creatinine hangs out around 2.
Yeah.
Sometimes he's at 2.5. You know, he's got a uric acid of 12.
Ouch. Yeah.
Did I have enough guts to put him on allopurinol? No, I didn't want to get the phone call from his cardiologist and his nephrologist.
Well, first you're going to get a phone call from the pharmacy, and second you're going to get hate mail from the pharmacy saying that you're trying to kill your patient with allopurinol.
No, they
Right.
didn't know what his creatinine was. I wouldn't get that.
Yeah, no, they usually write that patient has evidence of chronic kidney disease by your billing codes and is on 300 milligrams of allopurinol, and basically you need to consider those adjustments. So yeah, with GFR under 30, and that's where there's a controversy. If you look at PI, you do not adjust allopurinol up until GFR of 20. If you look at American College of Rheumatology previous guidelines, they actually recommend no more than 100 milligrams for GFR under 30. What do you follow? It's kind of up to you, but you know, if you want to stay away from the lawyers, I would say under 30, 100 milligrams of allopurinol max. That doesn't work, then you have Uloric. Yes. And there you do not do dose adjustment. So we'll talk about that. So if you start allopurinol, what dose do you do? Do you gauge it against uric acid? Do you start low, go slow? How do you do it? Start 100? Anybody else? That's kind of consensus?
Maybe start with 150.
So break over 300 in half?
Yeah, if they're already on colchicine, you know, around the 6 months, and you're having it at that point, but you're less likely to cause, at least in my memory, precipitation, so you go higher at that point.
Right, so basically if they're on colchicine, and these are actually data from the Uloric studies, I believe, where they started on 40 and up titrating to 80 of Uloric. So this is a hefty dose. This is start of 300 plus milligram equivalent of allopurinol. It's 0.5 flares with prophylaxis. So yeah, I mean, it is sensible. Once again, considering the costs, okay? Kind of your press release for New American College of Rheumatology guidelines for treatment of acute gout. And we talked about diet, disease process, and all that. Xanthine oxidase inhibitors, yes, start, okay? First-line pharmacologic therapy, okay? Lower to less than 6 at the minimum, okay? And the third thing is initial dose of allopurinol no greater than 100. And I explained to you how it works in my practice now. I used to start them on 100. What now actually changed is this. You start them on 50, 2 weeks to a month, go to 100, then go to 200 another month, then 300. Have that cold crisp prescription, not prescription, but pills on hand to start, self-start, okay, at the first twinge of gout and continue if it happens. That way, I did my statistics, 80% of patients do not flare at all. So you spend no money on cold crisp, you avoided the flares, and that works, and that's actually what's recommended.
In addition to diminishing the acute flares, is there some advantage to identifying those who are going to have an immune response to the drug and have a milder, is that any of the motive to avoid triggering the potential Stevens-Johnson syndrome? Or is that
Oh, this is a great question, yeah. So, yeah, what is interesting, basically, are there any other advantages to that therapy? This is a great question because what happened when Europeans actually have a European registry for Stevens-Johnson syndrome. And what they found is actually that disproportionately patients who are in registry started on high dose of allopurinol right away, number one. Number two, were exposed to higher doses of allopurinol. So even theoretically, it's idiosyncratic reaction and should not be dose dependent, but apparently it is. So basically 300 or higher starting dose and the treatment dose of 300 or higher associated disproportionately with higher incidence of Stevens-Johnson syndrome. Obviously, there's no controlled trials, but that seemed to be kind of everybody's feeling. Not only you avoid the gout flares, but you avoid the Stevens-Johnson that way too. So that is a great question. There's great disadvantage to that method, which is you bring patient again and again, and they can get tired of you. So fit it into other things so they don't, especially if they come without flares, they feel like they wasting their money. You're collecting their co-pays, right? That's only purpose of it. And you try to explain to them, yeah, I mean, you're feeling well and nothing is happening exactly because we're doing it slow, gradually. And one visit to emergency room will pay not only all my co-pays for you, but for 10 or 20 other patients. So that's the idea there. But you have to explain to the patient. Plus, if you hit uric acid of 4.5 with 200 milligrams, why bother? Why go any higher? And that's my point. We're good? Okay. So other thing is, I never knew that, and that is totally fascinating to me. They're talking about that Koreans with stage 3 or worse kidney disease, or Han Chinese, or patients of Thai descent. Apparently there is particular HLA type, okay, tissue type, that antigen type, that is associated with high risk of adverse reaction to allopurinol. And in those patients, you really have to go with much, much lower doses. And don't up-titrate them. Exactly, I kind of like, ouch. I didn't know that. So, so something, if you happen to have the population of patients like that, that may be patient I would, if there is appropriate financial situation, I may consider doing Uloric on that. What else is interesting there? And otherwise, yeah, they talking about, hold on, it kind of flips on me. Yeah, so yeah, you initiate, when you have a flare, that's that part of guidelines. You initiate within 24 hours. Continue urate lowering therapy. Patient oftentimes starts. So physicians oftentimes said, okay, you started you on allopurinol, uroric, whatever, titration, and you develop flare. Oh, let's stop it. No, keep going. Also keep going with all other medications, with your aspirin that may be actually helping to keep uric acid up. Niacin keeps uric acid up. So things like that. Keep everything going. You do not want any additional disturbances in the uric acid level and restructuring of these crystals, restructuring of this tophi. So do that. Once again, they recommend colchicine a low dose of NSAID. That's where we are. So now back to our good old friend colchicine. No, I'll show you one more slide, actually, before we go to colchicine. All right, we'll skip that. Yeah, obviously nobody going to look at normal uric acid of 8.5 or less. This is just what is prevalent within 95% of normal range in some labs. You should just totally ignore it. This is very interesting study. It is a Japanese man, so it's not totally Olympia population. And this is on treatment uric acid and probability of flare in the year. What is interesting here is this. So above 7.5 actually, uric acid, it looks like you have 60+% risk of flare. So if you have somebody on 300 milligrams of allopurinol and you 6.1, 6.5 even, well, yeah, that's your risk of flare here, about 25%. Is it acceptable? Once again, if it's your co-partner, you may consider. Otherwise, you talk to the patient, they really don't care. You say, well, we may keep it here. Same situation, your co-partner with a uric acid of 8 on 300 milligrams of allopurinol, what are you going to tell him? No way. No way. You got to have it lower because it is not acceptable risk. So that kind of the number, at least I remember, definitely above 7.5, I would say that's an upgrade call. And yeah, I think it comes to $35 a month, I think, with a copay card for most privately insured patients. So $1 a day, $365, maybe a little more per year. Well, that's probably a price to pay. Or, modify your lifestyle, lose weight, and have a happily ever after, right? So, but I think that's an important slide to me because I think it's practical and gives you some guidance. Yes, under 6, for sure, to eventually eliminate flares. If you are above 6, between 6 and 7.5, you will have continuous, persistent, lifelong, probably flare risk of about 20–25% per year. So consider this. And once again, you can do better than that. We skip through this. So treatment options. So acute attack, and that's where we got our expensive Colchris, right? I mean, it was a genius business enterprise, right? To take a medication that was at least 1,500 years old and make it a branded one. And URL Pharma did a fantastic job. They worked with FDA. I'm pretty sure FDA commissioner, so their relatives. Never mind, I didn't say anything. But basically, yes, it cost what it cost. Saying that, actually, URL and Takeda were actually quite good to making sure a patient who need it will get it. Actually, the best thing is to have a Medicaid now. Because, yeah, it's there. That's not a problem. It's a choice. Yeah. Worst thing, as always, is to have Medicare, right? Because you can't use copay cards, and you have endless harassment and all this. But it's a different story. And Jason over there, he'll work with you and explain to you some of the tricks of the trade, which are changing, obviously, weekly. But that's where we are. So two gout indications that Colchicine is approved for: acute flare, flare and prophylaxis. We're going to skip this. Probably what was maybe worse the price that we pay for it is this. FDA made company to do pharmacokinetic study and formal efficacy study. Now, who remembers Washington Manual? Something, yeah, fantastic book up until you actually graduate and it's no longer attending rounds you use it for, or your senior resident rounds you use it for to answer questions, but actually have to practice, right? So what did it say for gout? Good old way, right? Have one pill every 2 hours up until symptoms relieved or diarrhea develops.
Or 6 max.
6 max. It was 8, at least it was urban legend on the East Coast. But anyway, so yeah, it never got there. So question is, if you do this, how many patients, what proportion of the patients that would get a relief in the first 24 hours? Do you have like kind of your estimate from your practice?
Pretty high.
Pretty high? You say 50, 80?
Like 80.
More like 80. Okay, very good. That's what that's what I thought. Okay, but I could not really recall the faces of the patients, thankful patients coming. What I remember, the patients who were calling me that saying the food still hurts like hell, and now I have diarrhea. I cannot make it to the bathroom in time. And you come to my house and gonna clean the mess. That perspective really doesn't sit well at the family dinner when you try to explain why you have such sour expression while taking a bite of your wife's cooking, right? So anyway, so what the company did, and I would say I have to be very thankful for this, is this, okay? Number one, they did the traditional Washington Manual recommendation, high dose colchicine and low dose, meaning 2 tablets right away, hour later, 1 tablet. That's it for the first day. There's no difference between response rate, and it's not 80%. Ouch. So 33, 38%. Placebo is actually not that bad of a drug. I didn't think you can resolve gout flare within first 24 hours, but placebo does it. Okay. Now, side effects. If you use high dose, diarrhea, 77%. So 32% will get relief of the symptoms, and 77% going to get diarrhea. We were doing a fantastic job with treating patients with Colchicine through most of our careers, apparently. Either they were too polite to tell us that, or whatever else, or we have a selective memory, which I totally admit I do. But yeah, that's kind of where we are. So bottom line, forget what you've been doing in the past. And that may be kind of one good thing that came out of relicensing of Colchicine. Okay? That do not do torture of the patients. Okay? So that's number one. So 2-in-1 prophylaxis, 1 or 2 tablets. Actually, I can give you a dirty secret. Half works too. Not bad. Especially kind of later on, once patient got through the first 6 months. And I tend to, once again, if they can afford, I tend to keep them for a year because there's another mobilization flares happen up to a year. Really important patients. I give them half. It still works. What also important things that came is adjustment for decreased renal function, adjustment for transplant patients, adjustment for HIV patients, adjustment for patients with 3A4, which include clarithromycin. Otherwise, it's mostly HIV medicine, verapamil, things like that. So if you just remember, ring the bell, transplant patient, HIV, renal failure, severe hepatic failure, consult package insert. It's all there. And they're fairly complicated dosing regimens for advanced renal failure, for, not recommended for patients on cyclosporin with renal failure and stuff like that. So basically, keep in mind, it becomes toxic. And it has muscle toxicity. And by the way, there are reports of toxicity of colchicine plus statin increasing myopathies. So don't ignore that. Once again, I would almost proactively, in patients who you think prone to that, drop the dose to half. So that's where we are there. Also, why not just to keep people who can afford it or can smuggle it from Mexico or Canada, keep them on all Colchris forever for prophylaxis, especially if it works for them? Well, that's the thing, because myelosuppression can still happen. Keep in mind, it's still toxin. You know, it's a toxin out of the bulbs of an autumn crocus, and it's there because it didn't want to be eaten. It wants to give severe side effects to any creature that eats it, which it does. That's where we are. So now question is, why do we need Uloric while we have allopurinol, right? Well, a couple things. One is it's totally different molecule, and there's quite a few people who are allergic to allopurinol, not necessarily with Stevens-Johnson, but with just plain old rash. Say again?
Histamine reaction.
Well, basically, it's kind of your classic allergy, right? Classic allergic reaction that we can treat with Benadryl and stuff like that. But it still does happen. Okay, so it's totally different structure. There's no cross allergy. It can cause rashes. There's, I think, one case of Stevens-Johnson that's described in patient on Uloric without cause or effect known, but it happened. But at least in the FDA delayed release of Uloric forever, I think it's something like for 10 years. So there's a lot of safety studies accumulated. There was any significant severe drug reactions from the side of the skin. So that's number one. Number two, once again, renal. When you have renal impairment, especially severe one, when you need to get to the target, allopurinol not going to cut it. That's why I stand here and speak to you, because I use quite a lot of Uloric, because in patients with renal failure, that's what you got to do. I do it for other reasons too, because it's not only prevents gout, but there's some off-label uses. I use it for sometimes kidney stones, but you can use allopurinol there. But anyway, so here's what we have here. Why do we need allopurinol? And there are 3 studies, okay? And doses of allopurinol here, 300, 200, 100, 300, because if patients reached goal, they were not up-titrated. So patients who reached their goal of uric acid less than 6 on allopurinol 200 were not up-titrated to 300. So this is our actual real-life experiences of up-titration schemes. And as you see, you have about 40% max of patients reaching uric acid goal less than 6. And with Uloric 80 milligrams, it is somewhere around 3/4, 2/3 to 3/4. So it is better. It's definitely a step up. In Europe, it's approved up to 120 milligrams. It's not approved in this dose here. But once again, especially in consultation with a rheumatologist and severely, patients with severe symptoms that are persistent on 80 milligrams, that's something you can contemplate as well. Would be off-label, obviously. That part, we'll skip that. And that is important part, which is side effects. And as you know, we check LFTs on allopurinol. There are sometimes just benign LFTs elevation, like on statins. Nobody knows why we're checking it, because package insert says so. Actually, there's plenty of literature in lipidology saying we really should not be checking LFTs in patients on statins, because it's just a nuisance. Probably kills more patients than saves. Nobody ever required liver transplant or died of liver failure on statins. Nobody did it on Uloric. On allopurinol, you sometimes have idiosyncratic fulminant hepatitis, though. Very rare, but I've seen at least one case in my practice back in Temple. So anyway, but these are liver function test abnormalities. Once again, it's definitely more than placebo. It's just that's just the difference in probably noise level. There's no dose dependence there. But you need to check the ALT once 2 months after, and as package insert says it, periodically thereafter. Once again, it's no worse than allopurinol. So no worse here. Now that is thing that, once again, when patient consult with Dr. Google, as they always do, they come to you and saying, you're trying to kill me, because that medicine is increasing rate of cardiovascular event. And we always thought allopurinol actually decreases cardiovascular event rate. There's several studies, smaller studies, that were specifically designed to look at cardiovascular events with allopurinol that showed that it decreases that, decreases renal events, things like that. And all of a sudden, in all the Uloric registration trials, we have a signal not only for Uloric but also for allopurinol of increase in cardiovascular events. Now, those of you who had been doing academic and statistic discussion in academia, which are probably the most boring things of all, okay, will pick up the problem with this whole slide, okay? And it is very obvious there why this basically this analysis should be thrown away right away and not even looked at. Takeda is doing the phase 4 study, which formally evaluates cardiovascular event rate in patients with gout randomized to either allopurinol or Uloric. It's not going to report anything for 5 years if there is no signal. But one thing you need to always look at this is this: what's the rate of placebo? It's total, complete zero. Okay. When your control arm has 0 events, I mean, this is underpowered study. You cannot really make any conclusion out of it. So you need a formal study. That's more likely than not to be noise. Once again, it is in PI. It's on Dr. Google. It is pretty much the same for allopurinol as it is for Uloric. So to me, this is not an issue. If that's an issue for any of you, please voice your concern. Patients will ask you. So that's where we are. And that we talked about this. And we are skipping through all this. How about this? Oh, yeah, that's where this slide is now for the crystals. Remember I told you about crystals in the joint? So it is here. But otherwise, it is thank you for the first part. This was half meal part. How are you doing on the meal? You still on a salad? No. Oh, your dessert?
Dessert's done.
Woohoo! All right. How are we doing on time? What's time?
20 minutes?
20
minutes
to 8?
for additional topics? Or
Oh, cool. All right. So please, let's talk about gout management. Give me the questions, and then we'll look at, let's see what we can get, if there's any desire to get out of other tapas.
If you start Uloric, you have to titrate up, or?
So the question is, if you start Uloric, do you titrate it up? I generally do not start Uloric except for special circumstances. I start allopurinol, titrate it up. If I don't get to goal, yes, 40 of Uloric seems to be just a touch more than 300 of allopurinol in regard to uric acid lowering. So I generally upgrade him to 40 of Uloric, which is consistent with package insert, by the way. You start with use 40 and go to 80, and then I go to 80. Okay, but I do not expect much of additional uric acid lowering. I do it just for the sake of that start low, go slow concept. So yeah, I would do that. So I would go 40, 80.
While we see the evidence of these inflammatory flares in joints with uric acid issues, what's going on in the kidney? Are there acute issues with kidney damage with uric acid deposit aside from stones in the kidney?
So question is, what's the deal with uric acid and the kidneys? And to make it a quick answer is there's probably something going on. Okay. Question is what? Obviously, uric acid is concentrated in the kidney. The problem is that up until very recently, we have no way of fixing the tissue without dissolving uric acid. So you could never find, and the same problem was with the vasculature. It's actually in the University of Washington, there is one fellow who figured out highly secret way of fixing the tissue without resolving uric acid. So he finds microtophi now in the vasculature, in the kidney, everywhere. Okay, so apparently it's there, and how much it is actually contributing to, for example, vascular inflammation and plaque, and maybe that's why you have allopurinol affecting the angina incidence and things like that. That's quite maybe. But bottom line is there is uric acid in the kidneys, and we know the higher the uric acid is, the more you're going to have progression of renal disease. We know also, once again, smaller, less controlled studies, that allopurinol decreases proteinuria, decreases progression of renal disease. Once again, no large study for that, but at least what myself and other nephrologists, I understand, most of the time doing, we're trying to elicit history of gout from the patient who we otherwise on optimal therapy, keeps progressing, has high uric acid in their serum. You know, I kind of gently nudge them to ask him, hey, maybe you remember having the inflammation of big toe after the 4th of July or Labor Day. And they look at me, Doc, thinking of it? Yeah. So I said, this is a great news because that's what we can do. And once again, small numbers, biased experience, but more often than not, I see the stabilization or sometimes improvement in renal function. Same, once again, biased experience, the anecdotes. I see changing from allopurinol 300 to Uloric in patients with Uloric 80 with patients who uric acid still above 7 or up. Renal function also tend to improve. Anecdotes, okay, no controlled studies. But once again, patient who has uncontrolled uric acid, has history of gout, that's just additional reason to do it. Not just for gout, but also for putative kind of cardiovascular and renal benefits. You want the menu back? Or it's up to you, or more gout?
Maybe you can comment on the relative amount of hyperuricemia from our various diuretic options.
Okay, that's a...
Versus furosemide. I mean, there are different settings
Yeah.
for using these drugs, but where should we have a heightened
Right.
concern?
You come with absolutely fantastic questions. And so question would be, let me put the menu back. Here we go. All right. So question is diuretics and uric acid. And traditionally, we think that thiazides are the worst offenders. Okay? And spironolactone is the least. Okay? But there's different views basically among gurus of nephrology. And the last time I talked to Burton Rose, who is, was the original starter, basically the father of UpToDate, and his actually feeling was that it all depends on the amount of actual volume depletion that occurs. Because if you use, once again, furosemide, it's not very effective diuretic. Yes, it makes you run to the bathroom for 6 hours, but after that, your net effect is usually close to zero with, once again, day furosemide. Longer-acting thiazide diuretics have much more perceptible effect on continuous mild volume depletion. And what mild volume depletion does, it makes you reabsorb the sodium in every possible way, including upregulating the sodium urate cotransporter. So basically, as long as your body feels a need to reabsorb sodium, which comes with volume depletion induced by diuretic, you will reabsorb uric acid. So it's pretty much inevitable. So you can almost gauge the diuretic potency by the net effectiveness of diuretic on producing consistent volume depletion by how much your uric acid went up.
Is that the mechanism that happens in preeclampsia also? We see elevation of uric acid?
Yeah, exactly right, because they reabsorb sodium so much, they avidly reabsorb sodium, they swell up, they reabsorb, yeah, the uric acid goes up. So it actually overpowers the estrogens, right? That's supposed to be uricosuric at that kind of point, right? No, and that's what happens with hyponatremia too. That's why you have an SIIDH where you have mild, usually subclinical volume expansion. If you check uric acid, it's low. That's how you distinguish, one simple blood test in SIADH from diuretic induced, for example, or other hyperuricemia, yeah, other hyponatremias, right. So basically, if uric acid is down, you have a relative volume expansion. If you have somebody who has SIDH and you're wondering if they're just not drinking, eating enough, not enough salt consumption, check uric acid. If it's a little bit up, yeah, it's not SIDH. So yeah, same mechanism. I think we have time for one more. Any favorites? Yeah, go ahead.
The systolic BP variability and its significance in guiding antihypertensive
Wow.
therapy.
All right, so picked up the hardest one. Okay, that's good. So if you have a headache tomorrow morning, it's not wine, it's me. Okay. I actually did present that with Matt White, who did cardiovascular symposium here, CME, last year, I think. Anybody was there? No? Okay. Very good. So let's look at that, okay? That is almost there. Here we go. All right. So systolic blood pressure variability. This is that patient that comes to you with a home blood pressure record, averages. You know, everybody has Excel now. Everybody is smart. They, line them up, and they get the average blood pressure, and it's 134/82, perfectly in the goal of under 135/85 per GNC7. Something to celebrate. You say you are just fine. And then you realize that by statistics, actually majority of patients who have strokes are actually those whose blood pressure is either controlled or plain considered normal, not needing treatment. Ouch. So there is a dissonance there. Also, there is big dissonance with, for example, beta blockers that lower blood pressure, but for the amount of blood pressure lowering, average beta blocker lowers systolic blood pressure by 10 points. It's at least 4 to 8 multiplier with regard to risk for every 10 points. So 10 points of systolic blood pressure elevation by Mr. Fit data multiplies your risk of stroke 4 to 8 times. So why is it that decreasing the blood pressure by 10 points only gets you even into non-statistically significant decrease in risk of stroke with beta blockers, unlike other medications? Another little piece of puzzle that we don't know. And why is it not decreasing all-cause mortality? That is a different story. And that goes again. This is all the trials. This is trial called ASCOT. Once again, atenolol thiazide, risk of stroke versus amlodipine perindopril was quite striking. So question is why? So here's your blood pressure variability. How much blood pressure, that excursions of blood pressure up and down with in the ASCOT trial. And as you see, with the start of atenolol, it actually went up quite dramatically and stayed up. It decreased later because you actually add thiazide diuretic to the mix, and majority of patients were on multiple drugs. And then you add actually alpha blocker, and then you add spironolactone. So that was the up-titration scheme there. While actually your amlodipine dropped it quite dramatically. Another trial is MRC trial, a Medical Research Council trial out of England. Same thing, atenolol, diuretic, placebo. And at 12 months over here, what happened? If blood pressure was not controlled, they were allowed to have the drug from the other arm of the study added. So once atenolol group had actually thiazide diuretic added, it actually went down. Okay, the same, and while thiazide diuretic had atenolol added, it actually went up. Very interesting. Right? So we're talking about variability. Also, when they looked at the risk of strokes, and they sliced it and diced it, all patients who had clinical stroke, patients who had stroke, clinical stroke, or TIA or CT evidence of previous stroke, that's your risk depending on the decile of the blood pressure variability. So patients in the 8th, 9th, 10th decile had multiple of 11 of the stroke risk, adjusted for average blood pressure. So if you have exactly the same average blood pressure, but you have the higher decile of variability, your risk of stroke is 11 times higher than the people with the lowest. This is the strongest, biggest multiplier you can imagine. Not that much for coronary heart disease events. Probably on the level of 2 to 3, but that's something to think about. How about that maximum blood pressure? You know, patient comes to you and has, occasionally goes to 180 and say, it's okay, too much coffee, a little bit too much argument with your mother-in-law, something like that, we'll do it, don't worry about it. Well, not quite, multiplier of 17. Yeah, I was looking at it like, well, tell me good news, because this is kind of depressing. Now I kind of understand that majority of my patients are still walking strokes in progress, basically. Here's kind of hint of benefit, okay? This is distribution of ASCOT trial, and I know it's a little bit difficult to interpret. Don't look at this one, look at this one. Basically, what happens here, this is distribution of number of patients, different treatment group. Red is atenolol, and blue is amlodipine. And look at this part, okay? With amlodipine group, the number of patients in the 10th decile were much lower than with atenolol. So basically, once again, atenolol tend to increase blood pressure variability, higher risk of strokes, and once again, higher variability compared with amlodipine. And that's exactly what it is. So question is, if you now know the enemy, you need to know how to treat it, and it's in your handouts. Once again, amlodipine or dihydropyridine calcium channel blockers in general, and diuretics, especially long-acting thiazide diuretics, decrease variability. Beta blockers increase, ACE inhibitors also increase a little bit, ARBs more or less neutral. And it totally explains the results of a lot of clinical studies that we know with regard to their effect on strokes. But bottom line is switching away from beta blockers to amlodipine and diuretics, and from sometimes even ACE inhibitors if there is no specific indications to diuretics and amlodipine seems to be the way to avoid strokes. It may increase your risk of heart failure, heart attacks, but if you ask patients what they fear most, it is strokes. It is strokes. So this is in your handouts. This is my instructions to the patients. About 90% of them can handle it, even the patients who never use Excel. Basically, it's standard formula in Excel how to calculate standard deviation. What you tell them to do, they measure it at home. First thing in the morning, they got at least 7 numbers. They highlight them, they put them into formula according to instructions, and they got the number. You change the treatment. After a couple of weeks, you do another week of the blood pressure measurement. You do another standard deviation. It looks better, great. Because otherwise, you see blood pressure going this way here, and this way here. How do you know that this is better than this or worse? You don't. You need specific number. That's what it does. So simple Excel does it very, very easily. So once again, can you integrate it in your busy practice? I don't know, but at least it takes 10 minutes of one visit to explain the concept for me, and about 5 minutes on a follow-up to kind of go through this.
Symptomatic activity and beta blockers are not all the same. So if you have to use a beta blocker.
Yeah, with the beta blockers, basically there's a couple of things, and these are some of my personal observations, that carvedilol seemed to be at least neutral, and nebivolol bistolic seemed to be devoid of that feature of beta blockers of increasing variability. Switching from traditional beta blocker metoprolol or atenolol to nebivolol actually does sometimes very dramatic decrease in blood pressure variability in my patients without affecting much of a heart rate or blood pressure, right? Once again, without the tool, without knowing that it decreases it, you wouldn't be able to do that, okay? But the way basically, this is show me the money concept, okay? If it works, keep it. If it doesn't, try something else. For some of the patients, I change them from ACE inhibitor to Tecturna. Works fine, worked great. In others, it didn't, but you at least have a tool now, a gauge to measure whether it works or not. So that's the benefit of it. And it's in your handout. Over 10 standard deviation usually means it's bad. I mean, it's your 8th to 10th decile. Under 6, it's beautiful. So if you can get away under 10, it's already good. If you get to 6, you pretty much can give them warranty card against the strokes. If their carotid's clean, their lipids okay, average blood pressure is okay, variability is okay, there's practically no chance outside fractured aneurysms.
Now, the Spanish showed a nighttime lisinopril,
Right.
Had an 80% lower stroke rate in men than a morning
Mhm.
lisinopril. Do you encourage your
Right.
patients to use bedtime doses or
Very good. Yeah, and I'll show this slide, even if you don't want me to, because I think that's way too important to miss. And thank you for bringing it up. But so that's that. I think that probably you have the final points here, exactly that. Drugs increase, the drugs decrease. Okay, and the point that Gary was making, I just show you the few slides. When you dose medication is probably as important, and this is from this particular study on chronotherapy. This is actually randomized, controlled, single-blinded, actually it's open-label probe design, so open, prospective randomized, open-label, blinded endpoint assessment study. Pretty much only, so it's almost like real life, except that the people who adjudicate the event, they blinded to allocation. So when they say patient had stroke, they don't know which treatment group they are allocated to. But what they did, A, it's 24 BPM study. Number 2, they randomized patients to either at least one drug at night or all drugs in the morning. And it's actually, for current measures, pretty big trial with pretty long follow-up, so that was all good. And that's your Kaplan-Meier curves of survival. And as you see, event rate was not that big, but still there was very significant difference. That's what happens now in all clinical trials. All of them ended up being somewhat underpowered because people we're enrolling in are too low risk. We don't enroll train wrecks. You know, I do clinical trials, and I see patients who qualify there, they're not going to have events. You know, they have, post-MI patients to qualify for example, Cantos trial of Novartis. It ends up, there are people who are never going to have events. They're all very healthy, very compliant, very good people. So that's your outcomes. And exactly as Gary mentioned, stroke risk down by 80%. Now, what's additional cost? What additional incremental cost of that intervention? Taking your medication at night instead of in the morning. It's exactly 0. Who will make money on it? Are you going to come to the hospital and say, why don't we do the right thing and start dosing antihypertensive at night in the hospital? We prevent 80% of strokes and 60% of heart attacks and things like that. Nursing union not going to be happy with that. Because, yeah, this means more work for the night staff. And they don't want it. And the pharmacy going to have an extra pharmacist and everything else. So all of a sudden it's a mess. But I can tell you, in my hospital, actually a pharmacy, at least for one specific situation for heart failure patients, yes, we're dosing now ACE inhibitors and ARBs at night. At least we have a protocol there for a particular subset of heart failure patients. Yeah, it says give at night. So once again, in your practice, how long does it take to communicate that to the patient? 10 seconds. Okay? They ask you why. I say, because you're going to live longer. Or I tell them right away, if I don't have time for them to connect that, I said, you're no good to me dead. If you don't...
They get confused and they take their diuretic at night and they come back and curse you for pissing.
That only happens once, you know. It's like minesweepers. They only make one mistake in their career. So the most patients, first time they do make that mistake, the second time they will remember. But yes, basically ACE inhibitors, ARBs, beta blockers, definitely, okay, going tonight. Amlodipine is the only drug where it didn't seem to make a difference, at least with regard to blood pressure control. Okay, so very, very important thing, I would say, to do that. Okay, and that's the conclusion of that. More questions? We almost made it through a whole menu, but you're good. Everybody wants to get home?
Oh, I think that's just been a great presentation.
All right, well, then thank you. Okay.